Thank you so much. Sorry I'm late. I don't know, anyone that's working at the QE2 knows the terrible parking situation currently, so my apologies. I'll just share my slides here. All right, yeah. So as Sarah mentioned, I'm a psychiatrist at the QE2. I also have an administrative appointment with the MAiD program as the medical co-lead, along with Dr. Gord Gubitz. So this presentation is kind of more in my role with MAiD. I did want to give a thank you to Dr. Terry Chisholm. She was kind of my mentor in getting me involved in MAiD work, especially as it relates to geriatric patients. She originally developed these slides and would have been here to present with me, but is currently visiting her daughter. So just wanted to give a thank you to her for these slides. Before we get started, I just wanted to acknowledge that MAiD is a very complex topic that can bring up a lot of emotions for people. And this presentation is not at all to try to convince you one way or another about MAiD. It's just providing information as MAiD currently is a procedure that's available legally in Canada. So it's normal to have a lot of emotions, especially conflicting emotions about MAiD. And so I just wanted to kind of acknowledge that and hold space for that. You also are well within your rights to have conscientious objection to MAiD. The main thing to know is that you do need to be able to refer it to someone who can provide MAiD. So I'm hoping that this talk today can help you kind of understand the MAiD process. And so if MAiD isn't something you're comfortable with sending a referral in, that you know kind of how to direct your patient either to self-refer or get connected otherwise. All right, with that being said, we have a few objectives for today's talk in kind of how we look at MAiD assessments in patients who have both dementia and frailty. So one of the objectives is understanding how the stages of dementia are relevant in MAiD, and we'll go into discussing why this is so important because a lot of this has to do with capacity and are people actually eligible for MAiD. The next thing is around frailty. So we get a lot of referrals for patients who are quite elderly and maybe don't have any one specific diagnosis, but have a lot of comorbidities. And we'll talk about how we use frailty to assess whether or not they might be eligible for MAiD. We'll also talk about capacity. And so it's really important in MAiD because that is one of the main criteria. And in order to be approved for MAiD is the patient must have capacity. And so we'll talk about what the different elements of capacity are and the factors that can impair capacity, which is really relevant for patients who are being referred with major neurocognitive disorders. And then the last objective I have here is that you can apply this to patients that you will see. Wanted to make sure you all know how to reach the MAiD program, who you can reach out to if you have any questions. We're always happy to hear from people if they're wondering if a patient's an appropriate referral or just want to chat about a case. So first of all, just talking about MAiD as it relates to major neurocognitive disorder. So the Alzheimer's Society, I'm sure you're all familiar with and recommend to patients frequently. So they actually have a section on their website about medical assistance in dying. And actually, just a few months ago, myself and a couple other members of the MAiD team in Nova Scotia did a presentation for the Alzheimer's Society because there's a lot of interest from patients who are newly diagnosed with dementia, wondering what their options are, particularly if they've had a loved one suffer from dementia and they kind of know what to expect. So just letting you know this kind of out there and people, it is something that people are talking about. So switching gears a little bit, talking about frailty. So I'm not a geriatrician. I think a lot of you that are here working in geriatrics, so you're probably much more familiar with this scale than I am. But just a reminder that with frailty, we do have kind of objective standardized ways of measuring frailty. So different scales that we have, and this can be really helpful for us as MAiD assessors when we're assessing someone's kind of trajectory of illness, what their lifespan is like, what their expected prognosis is. And so for us, we will often use the clinical frailty scale. We'll also use the palliative performance scale in looking at what someone's current level of functioning. Because one of the criteria of MAiD, which we'll go into later, is there has to be an advanced state of decline, right? So if someone on the clinical frailty scale is a 1, they're probably not going to meet criteria for MAiD because they're healthy, they're active, they're not in a state of decline, versus someone that is living with frailty is probably in that state of decline, which makes them more likely to meet that criteria. again, when we're assessing for MAiD, you have to meet all the criteria, but this is just talking about frailty specifically. So this study is really helpful because we know that most people who access MAiD are older adults. In Nova Scotia, kind of our demographics are most people who have MAiD are in their 70s, most with cancer. But this was a great study that was done in 2021, published in the Canadian Geriatrics Journal. So it looked at a MAiD database of 267 patients in a tertiary care institution, and showed that for patients under 80 years old, the most common reasons for accessing MAiD were malignancy, cardiopulmonary diseases such as COPD or heart failure, or neurological conditions. And that's kind of consistent with what we see here in Nova Scotia. However, for patients over the age of 80, we saw that they were more likely to be female. They're more likely to be living alone and widowed, and they were more likely to have kind of chronic illnesses. So the people over 80, as we can kind of expect, were less likely to have cancer, more likely to have kind of either chronic grumbling illnesses, things that were leading them to become increasingly frail, and loss of autonomy and independence. So a really common referral we would get here at MAiD is, someone in their 80s or 90s who's hospitalized with a recent fall, unable to return home, looking at possibly a nursing home, and they're kind of like, I don't want to continue to go on. So very different than assessing someone with cancer where we have, a known diagnosis, we have a known prognosis, here's the treatment options, they've used up all of them. Those are really straightforward cases. These cases where frailty is involved can be more complex. So this is a commentary published in the Canadian Medical Association Journal, which is really helpful in talking about how we assess frailty in older adults who are requesting medical assistance and dying. Because again, a lot of times when we think of MAiD, we think of people accessing it for, life-threatening diseases like cancer, like certain neurological conditions like ALS. And it's only been kind of more recently that we've started thinking about frailty and how it is also a life-limiting disease. So some of the considerations from that paper are that the clinician should have expertise in the patient condition. So a lot of times with MAiD, we're pulling on clinicians who have a wide variety of backgrounds. I'm a psychiatrist. A lot of our clinicians who do MAiD are nurse practitioners, a lot of emergency doctors, family doctors. So we all have a wide variety of experience. So at the MAiD program, we do try to tailor somewhat someone's level of expertise with the condition. So really helpful that, the people assessing someone for frailty have some understanding of what frailty is. You need to make sure to look at the complex combination of medical, social, and existential issues that can lead to frailty. So we're not just looking at, their medical comorbidities, but also factors like social isolation, depression, and food insecurity. Because some of these things are reversible. So if someone has food insecurity, can we get them connected with social work? Can we get that food insecurity resolved? If they have depression, has their depression been treated? Because these might be reversible causes of frailty versus things like their diabetes or heart failure, which are more difficult to reverse. We also know that frailty can improve after an episode of acute decompensation. So this article mentions how it's important that when we're assessing someone who's had an acute episode, an acute change in their frailty status, that we kind of make sure that we're not rushing to any conclusions. So if someone's had a recent, fall, broken their hip, let's kind of wait and see how things go. And sometimes we will do that. We'll feedback to the clinician, this person just had their hip replacement yesterday. Let's let things progress a little bit, see how they go before we do the assessment, because things can improve. That being said, it is much less likely the more frail someone is that it can improve. So this might not apply to all people. If it's someone who's already in a very advanced state of frailty and has a fall, this is someone who probably that's going to be their new baseline. So one of the criteria for MAiD is the person needs to be experiencing intolerable suffering. And this is something that is very individualized. So we know with frailty that the types of suffering that individuals experience are things like severe psychological distress, often due to their functional limitations, that loss of independence, that inability to care for themselves, as well as pain. And we have studies that show that they suffer to levels comparable to those with life-limiting conditions such as cancer. So one thing that's really important when we're assessing for suffering is that it's individual to the patient and it's the patient's own self-report. So we can kind of, say that how we might feel if the person is suffering or not, but really it has to be the patient expressing that. And sometimes I find, especially with older men, they're a little bit reluctant to say they're suffering. And so trying to explain to them, what suffering means and how that is a criteria needed for MAiD can kind of help them in being able to kind of grasp this concept. But the main point here is that the approach for how we both determine if someone is suffering as well as treat the suffering is going to be individual to each patient. And it shouldn't be assumed that just because they don't have, a severe pain disorder or cancer, that they wouldn't be suffering to the same level as someone with those conditions. Okay, so in MAiD, we have two tracks. There is track one, which is reasonably foreseeable natural death. And that means, it's not well defined in the legislation. So that is kind of up to individual clinicians to determine. But kind of how most clinicians would practice is, would you be surprised if this patient passes away in the next year or so of their illness? It really depends on the individual, but that's kind of the way that I tend to practice. Track two is non-reasonably foreseeable natural death, and these are really for cases where the illness that they're experiencing is not necessarily life-limiting. So these might be things like chronic pain conditions, trigeminal neuralgia, spinal cord injuries, where the person's not likely to die imminently, but they are experiencing suffering. So when we're looking at whether death is reasonably foreseeable in frailty, there's a lot of different factors that go into this. So some of the things, obviously are the severity of the frailty. So the more frail someone is, the more likely that they are kind of approaching end of life. The number of hospitalizations they've had. So the more hospitalizations, the more likely they're kind of closer to that as well as the speed of the frailty progression. So is this someone who's become increasingly frail in a matter of weeks to months, or has this been going on for years? There's some Canadian studies of community dwelling adults with severe frailty who report a median survival of 3.5 to 4 years. So this is something that's kind of helpful in being able to determine, okay, is this someone who is, dying imminently or not? Again, this is for community dwelling adults, so wouldn't necessarily apply to those in hospital. And we know that this survival rate would decrease if someone is also experiencing an acute illness on top of this. So this group that did the study on community dwelling adults kind of made a recommendation that it would be helpful to have a report with specific requests for MAiD for frailty so that we can do additional studies for this, because this is something that we're seeing more and more in patients requesting MAiD. Okay, so let's talk a little bit about dementia. So in 2017, an individual who had dementia had MAiD in British Columbia. This was then brought forward to the Physician and Surgeons College in BC, and there was a complaint made. However, the physician ended up to be cleared, and there's now been some kind of guidance from legislating bodies that dementia is an eligible condition for medical assistance in dying. So you may know that currently MAiD is not legal for a sole cause of a mental health condition. This has been a very contentious issue and has been delayed a number of times. Currently, the legislation states that it will come into effect in 2027. So we'll see if that happens. However, neurocognitive disorders are not considered a mental condition based on this legislation. So they are conditions that are eligible to apply for and receive MAiD. So the Canadian Association of MAiD Assessors and Providers, or CAMAP, is kind of the overall body that develops recommendations and kind of guidance documents. They're not a legislating body or licensing body, but they do provide a lot of oversight and guidance while not, able to kind of punish anyone for not following them. But they have a lot of really helpful guidelines and a lot of helpful resources in terms of best practices. So the CAMAP guidelines for assessing for MAiD in patients with major neurocognitive disorders are really helpful. And some of the main points that they emphasize, which, we should be doing with everyone, but special considerations for patients with dementia include it's super important to assess informed consent and capacity. So this is one of the main things that comes up with why patients with dementia don't meet criteria for MAiD because they don't have capacity. We also find that there's often communication challenges. So the patient might have word finding difficulties, expressive aphasia, or dysarthria. And so CAMAP recommends adapting your open ended questions to be more of yes no questions, as well as ensuring you have a quiet space, that the patient has whatever communication devices they need to help them communicate. The best of their abilities, as well as giving shorter questions with a lot of space in between for processing. In terms of how we can determine whether or not dementia qualifies for reasonably foreseeable natural death, so we know that if someone is applying for track one, their death must be reasonably foreseeable or predictable. We do know that most dementias are progressive and fatal, that people are not going to have a cure for their dementia. They're not going to outlive their dementia, um, except for certain instances. So things like a traumatic brain injury or someone that has a single stroke and is left with, deficits from that. They may not be the same level of decline or progression. So a lot of times in dementia, though the person is unlikely to maybe die in the next year or so, it is something that is a life-limiting condition. In terms of assessing for an advanced state of irreversible decline in capability, so that's one of the other criteria, is the person has to be in an advanced state of decline. We know that with dementia, patients have kind of live with that imminent, excuse me, risk of loss of capacity. So that's one of the things we want to look at, is where are they in terms of their current level of ability to understand and process things. We also need to look at things like physical decline and functional decline. So we oftentimes have patients who are applying for MAiD and have just been recently diagnosed with dementia. And a lot of times they're not meeting this criteria for advanced state of decline because it's really early in their illness course. Maybe they don't have a lot of symptoms yet. So it's important that we look at things like physical decline and functional decline when we're assessing whether or not someone meets criteria. So we often talk about, in assessing patients with dementia for MAiD, that there being this sweet spot. So they can't be assessed too early because they may not have intolerable suffering or be in that advanced state yet, but it can't be too late because they will likely have lost capacity. So a lot of times we kind of encourage people to err on the side of caution and apply, and maybe we're finding them ineligible at that time, but we're following along with them, reassessing them to kind of see where their illness trajectory is. Um, the really important point to emphasize here is that a patient must have capacity in order to be approved for MAiD. So if they don't have capacity before they're assessed, they are not eligible. Okay, when we're looking at causes of suffering in dementia, so this can be multifocal and things that we always explore in our assessments of patients with dementia. So the kind of number one thing that we see in these patients is the loss of ability to engage in meaningful activities. So a lot of times this is the loss of ability to engage in hobbies, doing things like reading, using technology, kind of loss of those social relationships. We see that patients describing suffering from being unable to do those things. And then the other big one we see is the loss of ability to perform the activities of daily living. So that causes a lot of suffering for individuals, no longer being able to be independent, having to rely on others for a lot of their care, having people come into their home. And a lot of patients will describe this perceived burden on others and not wanting to be a burden on others. Other causes are related to their physical decline. So kind of going back to the ADLs, like the loss of control of bodily functions and needing someone to kind of perform basic hygiene tasks, as well as the inability to mobilize, recurrent falls. And the other thing we always look at is emotional distress. So, how are they doing? Is there any concern for a mental health condition? Do they need a referral to geriatric psychiatry? Is there anything we can do to kind of improve that aspect of things? Because sometimes those things can be improved versus some of these others, because of the nature of dementia and its progressive nature, we can't really reverse. Okay, so just wanted to go over a typical case of someone that we might have referred to the MAiD program. So this is Mr. Journalist. He's an 89-year-old male who was a journalist. He has mixed dementia of a moderate stage. The referral indicates that he's experiencing decreased mobility. He needs help getting to the dining room for meals and requires 24-hour care. He's able to read the newspaper, but he reports that's pretty much his only, enjoyable activity day to day. The referral indicates that he's always wanted MAiD and it's been kind of a consistent wish for him. It also indicates that he had a recent visit to the emergency department with a fall, and he has had a history of multiple falls that have resulted in delirium and prolonged hospital stays. So he's currently receiving 24-hour care. However, he really is worried about kind of things worsening and worries about the ongoing risks of being in long-term care, and kind of his potential for additional falls or not being well cared for. So when we're assessing any case for MAiD, we have to look at, is this person in an advanced state of irreversible decline? So something that, it's a one-way trajectory, we can't reverse this. Do they have capacity? And is their natural death reasonably foreseeable? If their natural death is not reasonably foreseeable, but they meet the other criteria, they could qualify under track 2. And we'll talk about that a little bit later, kind of the differences between track 1 and track 2. Okay, so when we're doing a capacity assessment, so this is kind of common to any time we're assessing capacity for any decision. So as you all know, capacity is specific to whatever choice we're kind of looking at, and it can be different from one decision to another. So someone can be capable for finances, but not for healthcare, or vice versa. So when we're looking at assessing for a person's ability to provide informed consent, they have to be able to evidence a choice. So they have to be able to make this request in and of themselves. So it has to be coming from the patient that they're requesting MAiD. Someone can't make the request on their behalf. I mean, obviously, you're putting in the referral on their behalf, but it has to be generated from the patient. The patient has to be able to understand. So when we're looking at someone's ability to understand MAiD, a lot of times they don't have an idea of what the actual procedure entails. So the medications given, how it's administered, where it's done. So how we test for this is we will provide them with the information, and then, later on in the conversation, ask them to repeat back the information, and see what their understanding of it is. We're not expecting people to, know all of the medications involved in MAiD, but they should at least be able to tell us back that the medications are administered by IV, that there's multiple medications given, that they can change their mind at any time. Kind of the basic elements of the process is they should be able to understand that and kind of tell us about that back. They also need to be able to appreciate. So they need to be able to understand the foreseeable consequences that are relevant to them personally. So with MAiD, they need to understand that if they have the procedure, it will result in their death. And they need to be able to understand that. Or alternatively, if they choose not to go with MAiD or aren't approved for MAiD, what might be the consequences in terms of the natural course of their illness? So they need to kind of understand what their current illness is, treatment options, and what might go on in the future. So a lot of things can impair capacity. So we talk about the 4 Ds: delirium, dementia, delusions, and depression. So these are things that we're always assessing for when we're doing a capacity assessment, looking for whether or not a person is able to provide informed consent. So when we're looking at things like delirium or dementia, these often affect executive functioning. So a person's ability to plan, reason, problem solve, their concentration, attention, language, and memory. Big difference here is that delirium is often reversible. So if we can pick up on delirium, we want to be able to treat that, and hopefully see an improvement, and then perhaps the patient will have capacity. It's tough when there is an underlying dementia with delirium because we don't know necessarily what the patient's baseline is, but important to pick up on reversible causes of impaired capacity. In terms of delusions, so this definitely impairs people's ability to provide informed consent because it impairs their judgment in such a way that might influence their decision to die. For example, I saw a patient who was referred for MAiD, who had an underlying diagnosis of COPD. However, she had a delusional interpretation. She did not believe she had COPD. She believed she had this like traveling ball of infection in her body, and that if she just could have a CT scan, everything would be cured. She'd no longer have COPD. There'd be no more problems, but because her doctor wouldn't order a CT scan, she wanted MAiD. So she had a delusional understanding of her illness, and she would have qualified on the basis of her COPD. However, she did not agree she had COPD, did not think that was the cause of her suffering. So because of these delusions, she was not able to make an informed decision around MAiD. And the other thing that can it can impair capacity is depression. So again, this is also impairing someone's judgment in a way that influences their decision to die. So perhaps someone has, a moderate level of frailty, but because of their severe depression, they're requesting MAiD. We always want to try to look into that. So I always ask patients questions around suicidal ideation. For example, if you were not approved for MAiD, would you take matters into your own hands? Would you look at ending your life? And that can be really helpful because most people who request MAiD are not suicidal. They're looking to end their life in a way that is peaceful, with their family present with them, in a way that, is without any pain, versus suicide is usually done alone in a matter of, impulse. It's often painful. It's a completely different mindset when someone's looking at suicide versus a medically assisted death. So that's something we want to look at, because if they are experiencing suicidal ideation, we have treatment for that. And we want to make sure that someone is treated for their depression before we're kind of proceeding with MAiD. That being said, also really common for people to have low mood related to their physical illnesses and their inability to do things that they did before. And so it can be really helpful to differentiate, is this a depression that, would likely respond to medication versus is this a normal, adjustment reaction or normal low mood associated with their decline in functioning. So in terms of looking at how we might do an assessment for capacity when assessing someone for MAiD with a neurocognitive disorder, when we're looking at their understanding of the illness requiring treatment, we want to have the patient explain to us, what's your illness that you're requesting MAiD for? And again, we're not looking for patients to have a really in-depth understanding, that I have major neurocognitive disorder, Alzheimer's subtype. They should be able to say they have dementia, and that's sufficient. So we want them to know what their condition is, and they should be able to express some symptoms of it, but we don't need them to know all the fancy terminology. We want them to be able to say what the illness is and how it's specifically affecting them. So if they say, I don't have an illness, I'm totally fine, that's going to put up some red flags. So they should be able to know what their illness is. I'll give the example of a patient I saw a while ago who I ended up finding not eligible. And when I asked him what his illness was, he told me that his brain is red. And that was the extent of what he could tell me. He was a patient who had dementia. And so, that's not sufficient. They need to be able to explain in more detail what their illness is. The patient needs to understand their treatment options. And the really important one here, and what is legally required, is the patient must be aware of the alternative for palliative care. So palliative care is the main alternative to medical assistance in dying. And oftentimes we use the two synergistically to help manage symptoms and such. But it's really important that the patient knows that they have the ability to access palliative care, to ensure that they have had access to palliative care. So the patient needs to be able to understand that. They also need to understand the treatment, the reasoning for treatment, and the appreciation of the risks and benefits for treatment. So do they know that they're on a medication that's supposed to help slow down the progression of their dementia? Again, they don't need to know that it's a cholinesterase inhibitor, but they should be able to explain, I know I've been offered medications for this, they haven't been helpful, or they gave me too many side effects, so I don't want to be on them, as well as kind of palliative care options. They also need to be able to explain kind of their quality of life and what is causing them suffering. So, they might kind of describe some of this existential suffering about worries about what the future might look like, or it might be kind of more day-to-day stuff about they're in pain, or they have fear of falling, or that loss of independence, but they need to be able to explain that personally. So it's not enough that a family member can say, oh, they told me this last week. Like, we have to hear it from the patient that day in that assessment. So we always ask patients, what led to your decision to request MAiD? What got you thinking about it? How long have you been thinking about it? Have you told family members, who in your life knows about it? This is really helpful, because if someone's like, oh, I thought about MAiD yesterday and decided to request it, maybe we want to proceed a little bit more slowly, versus someone who's like, it's always been something, I was in support of, always something I've been thinking about. And as things have deteriorated over the past few months, I've started thinking about it more seriously. We always try to involve family members when we're doing MAiD assessments. There are certain situations, which I would say are the vast minority, where patients' families aren't in support of their MAiD request and they want to specifically not include their family in the assessment. However, for the most part, I would say, 95% of the time when I'm doing a MAiD assessment, the person has a family member present in the room with them. And so really helpful to ask the patient, how do you think your family member feels about that? And then kind of check in with the family member to see if that's accurate, because it's helpful if they've kind of thought about how it might affect others in their life. And then also looking at kind of death planning. So does the patient have a will in place? Do they have a funeral home arranged? Do they have a power of attorney? Have they thought about some of this end of life stuff? As well as, if you weren't approved for MAiD, or even if you were, would you ever think about doing anything to end your life on your own terms? Again, just a screening for suicide. The other part that we are doing is a mental status exam. And so a lot of this is done throughout the assessment, where we're kind of picking up on maybe clues that might lead us to think that the patient isn't oriented, or maybe they're experiencing some delusions. So in writing up my MAiD assessments, I always comment on things like, were they able to communicate clearly and effectively? Was their cognition, did it appear intact, or were there deficits noted? And did those deficits impair their capacity? Commenting on the 4Ds, so delirium, dementia, depression, and delusions. Were any of those present, and do they affect their ability to provide consent? As well as commenting on the patient's judgment and insight. So do they understand their illness? Do they understand kind of what's going on a day-to-day basis? Do they understand their illness trajectory? And are they making kind of decisions in keeping with their beliefs about their illness? Okay, so just going back to the case. So Mr. Journalist, who had mixed dementia of moderate stage with a recent worsening in terms of he had a fall, and he's had history of falls with delirium. Okay, so this patient, the big thing we want to know here is, do they have capacity? So especially in someone who's had multiple episodes of delirium in the past, as well as someone who has dementia, we want to make sure we understand whether or not they have capacity. So when we talk to this patient, we want to make sure he understands what dementia is. So like I said, we don't need them to know specifically that they have Alzheimer's, but they should know that they have a type of dementia. So whether they're explaining that as, I have problems with my memory. I mean, ideally they're saying the term dementia, but sometimes we can kind of prompt them on that, but they need to be able to explain what their symptoms are and what the illness, their understanding is of what their diagnosis is. He needs to be able to know what his treatment options are. So he was able to tell you that he's been living with dementia for many years. He's taking a medication for it, but he's not finding it helpful, and he doesn't think it's working. He says that he understands that with no further treatment, he'll only get worse. And he's really concerned about that because he doesn't want to go to long-term care. He is able to afford kind of 24-hour care in his home, but it's just not quite enough. And the way that his home is laid out, there's ongoing risks for falls, but he really just doesn't want to go to long-term care. When you're asking him about his quality of life, so he describes what you know as vascular Parkinsonism. He's not able to use those terms, but he describes very minimal mobility. He's got a shuffling gait. He needs a lot of assistance getting out. He used to be able to get out of the apartment every day, but he's having a lot of trouble with that now. In terms of the things that he does on a day-to-day basis, he reads the newspaper, but he's not really having any meaningful conversations or any social outlets that he finds meaningful. He says that he needs 24-hour care. He used to be very independent, but now he has a roommate in this assisted living facility, and he's just finding that to be really disruptive. He likes his privacy and just is not enjoying it. He has an appreciation that he can't do the things that he used to be able to do that provided him with a lot of meaning. And he can understand that his illness trajectory is that things will just likely continue to get worse from here. Okay, when we look at whether or not this is a voluntary decision on his behalf, so this patient tells you that he's always been interested in MAiD. He was a supporter of, dying with dignity before MAiD was legal. And he has already shared with friends and family that, he's a proponent of MAiD, would want it if he was ever in that state of illness. But he reports that his friends and family are all very supportive of his decision for MAiD. When we're asking around death planning, he says he would like to have the MAiD procedure in his room at the assisted living facility, surrounded by his close family, as well as his extended family who may be able to join virtually. And he reports that he hasn't considered stopping any of his treatments or stopping eating, and he doesn't have any thoughts or wishes for suicide. When we're looking at his mental status, so he's able to communicate very clearly with us. There's no issues there. With his cognition, he's a bit vague. He kind of wanders at times, gets off topic, but he's able to be refocused with prompting. does have some word finding difficulties. So he doesn't remember the term Alzheimer's, but he does know that he has dementia. Um, with his memory, he kind of knows the overall broad strokes of his illness, but can't tell you what he did yesterday or what he ate for breakfast today. He's very stoic when you ask him about suffering. And I had mentioned that we often see this with older gentlemen. He kind of says, "Oh, I get by." And so oftentimes with these patients, we have to remind them, hey, one of the criteria in order to be approved for MAiD is that you have to be suffering, and we need to hear something in your life that's causing you suffering. And so, sometimes we're able to kind of prompt people around that. Also throughout this assessment, they use more closed-ended questions just to try to help facilitate some of this communication. Okay, so overall, the result for this case was that the patient was deemed capable of making a decision for MAiD. He was able to explain his illness, explain kind of the natural course of his illness, understand the MAiD process. And due to the fact that he was kind of in a more advanced state, he had had these recurrent falls with delirium, was in an advanced state of frailty, he was determined to be a track 1 case, which means death is reasonably foreseeable, and he could schedule the procedure at the time of his choosing. One thing I should mention is that in MAiD, patients need to be assessed by 2 independent providers in order to qualify. So this would have been the first assessment. The second assessor would have done an independent assessment, not reading the first assessor's assessment. And if both people had deemed him eligible, then he'd be informed by the MAiD program he was eligible. The thing we want to talk about, though, is this patient's at high risk of losing capacity. And so the way that legislation works currently is patient has to have capacity at the time of their assessments, and they need to have capacity at the time of the procedure. So on the date of the procedure, when the provider is going into the home to provide MAiD, they ask the patient if they would still like to proceed with MAiD, and the person has to be able to say yes or no. And we know with illnesses like cancer, like dementia, things can progress to the point that people are, with cancer, more likely people are comatose, no longer able to communicate. With dementia, people lose their ability to speak, word finding difficulties. And so we do have a process in place where we can waive that final consent. So a person still has to be capable at the time of assessments, but we do have a process in place where we can waive the need to ask for consent on the day of the procedure itself. This is called a waiver of final consent, which we'll talk about. So the waiver of final consent is something a bit newer. This came into law in 2021. So MAiD has been legal since 2016, but in 2021, there was an amendment made called Audrey's Amendment, which led to the development of what we now call the waiver of final consent. So this is something that we can put in place, again, only to waive consent to them saying yes or no the day we're doing the procedure. It has nothing to do with consent for assessments. Waivers are only able to be used in patients who have a reasonably foreseeable natural death, so only for track 1 patients. They are patients who are at high risk of losing capacity due to their illness. And in order to enact a waiver, a patient has to be able to set a date to receive MAiD. So in completing the waiver, we indicate on the waiver, this is the date that I want to have MAiD. And if the provider goes that day and I can't say yes or no, I'm still going to have MAiD that day. There is a caveat there that if the patient, physically resists having MAiD, we will not do it. However, if they're not able to answer yes or no on that date, we're still able to do MAiD. So it's kind of an extra protection for patients, because kind of what led to this is patients were feeling that they were kind of pressured into getting MAiD earlier than they would like because they were worried about losing capacity and not being able to consent on the day of their procedure. So just some other things about the waiver of final consent. So in Nova Scotia, we have set our limits for waivers to be 6 months. So every jurisdiction kind of has its own way of doing things. It is not legislated how long waivers can be, but kind of our practice here in Nova Scotia is that patients can have a waiver of 6 months and then it can be renewed. And that's kind of around the fact that, if someone's requesting MAiD, most likely they're wanting to have MAiD imminently. And so if we're setting a waiver for a date a year from now, perhaps they're not really experiencing intolerable suffering and not ready to have MAiD, and maybe we need to reassess in the future. With that waiver of final consent, they are also able to have MAiD earlier than that date, should they lose capacity before that date. And we would rely on a family member to say, hey, they're not doing well, can you come and assess them? So really important that the patient knows when they're signing this waiver that they're going to have MAiD on that date. We always check in about a month before the waiver expires. How are you doing? Do we need to extend this waiver? Do you want to reschedule your date? How are things going? But it does provide some extra protection for patients at high risk of losing capacity. This differs from what we call advanced requests. So I don't think I have a slide on this, but I just want to talk about this briefly because this is something that is going to be discussed more and more as it was just recently made legal in Quebec. So an advanced request is completely different from a waiver. An advanced request is basically someone writing a personal directive saying, in the event I develop a dementia, I want to be assessed for MAiD. And so this takes out the part where the patient needs to be able to, make a request and be capable of making a request because they're making a request in advance. So when someone's making an advanced request, they do not currently have the illness that they, would want to be assessed for MAiD in the future. So this can get tricky because a patient would need to kind of list out in their advanced request what all the different possible illnesses are that they might want to have MAiD for and what their illness course would have to look like in order for them to receive MAiD. But the advanced request is literally a request to be assessed for MAiD. And then when we assess kind of their criteria for MAiD, we just wouldn't assess the capacity piece. So like I said, this is not currently legal in any province except Quebec. There's a lot of people advocating for this because for things like dementia, it is so tricky to time MAiD because so many times we're seeing patients where it's too late, they don't have capacity, they can't consent, so we can't approve them. So this is something that I expect will be more and more present and more discussed, and it'll be really interesting to see what goes on in Quebec. But yeah, it's really important to know about this because we not infrequently get referrals to the MAiD program. So we've gotten referrals for patients who are going in for surgery and they're worried about, that the surgery doesn't go well. They might have, like they're going in for brain surgery and one of the possible side effects is they might have some lasting neurological deficits and they want to be assessed for MAiD. They have to actually have the illness. So we can't do that unless they're actually having the symptoms and the illness currently. So if your patients are asking you about these advanced requests, you can let them know it's not currently legal unless they live in Quebec. We're also always happy if you direct them to the MAiD program because we can talk to them about this. And I just want to acknowledge it is a very complicated and complex topic. So if you have any questions around this, advanced requests and waivers, I'm happy to discuss. But kind of in a nutshell, a waiver is for someone who has already been approved for MAiD, was deemed to have capacity at the time of having MAiD, and it just allows us to not have to ask them yes or no on the day of the procedure. Versus an advanced request, not currently legal, allows someone to put in a request to be assessed for MAiD prior to even developing an illness, so that when the time comes that they have this illness, they don't need to have capacity in order to be assessed and approved. So I hope that's clear. It can be a bit complicated. Okay, so in summary, in talking about how we assess patients with both frailty and neurocognitive disorders for MAiD eligibility, hopefully now you kind of understand that people with dementia are eligible for MAiD. They just have to be in that kind of sweet spot of being able to still understand their illness, but suffering enough that they meet those criteria. Waivers can be really helpful. Advanced directives aren't currently legal. Frailty is a huge component of the MAiD assessment and often helps us determine kind of whether someone's death is reasonably foreseeable or not. A capacity assessment, always necessary in every single MAiD assessment, but very, very important when we're assessing patients with neurocognitive disorders. And then be ready to answer questions about MAiD. Your patients are likely going to ask you about it, and so it can be helpful just to know where to direct them to and just to have some resources on hand that you can kind of be able to explain things to them. When we're looking at how we look at capacity, so the elements of capacity, they have to evidence a choice, has to be voluntary, they have to understand their illness, they have to be able to explain their reasoning, and they have to appreciate how it applies to them. The 4 Ds that impair capacity: delirium, depression, dementia, and delusions. We always look for those. Okay, and then, I did have a slide on advanced requests. We already talked about that. Okay, so yeah, so advanced requests are becoming more of a thing. People are advocating for them, so I expect we're going to hear more about this in the future. Okay. All right, happy to answer any questions. I also just wanted to indicate the contact information for the MAiD office here. You can also access our website. So if you just Google Nova Scotia MAiD program, we have a website with a ton of resources for both patients and providers. We're also really happy to talk to clinicians at any time. You can email us, maid@nshealth.ca. There's our toll free and our local number. And I'm also happy if you want to reach out to me directly by email. Very happy to discuss any cases you might have or any questions you might have around MAiD referrals.
Shiloh, thank you so much. That was really, really well done. And I think I've heard some of this information previously, but the part about the the part about being able to waive the final consent is really important for our
Yeah.
population. And I'm with you. I'll be watching carefully what happens in Quebec because I can truly appreciate the desire to have some sort of advance discussion because for a lot of people, this is about control, right? This
Yeah.
is about control and self-control and being in charge of your life, which I can truly appreciate.
Mhm.
So thank you very much for doing such a comprehensive job and being so articulate about it. I know it's a tough topic. We do have a couple of questions.